Today's lecture is going to be clinical pearls for primary care, treating attention deficit hyperactivity disorder, ADHD, in children and adolescents. My screen is not moving. There we go. Okay, so today's goals and objectives are as follows. At the end of this presentation, participants should have increased information to identify the signs and symptoms required to appropriately diagnose ADHD in children and adolescents, provide examples of how to screen and assess ADHD in children and adolescents, and then describe the different treatment options to consider when treating children and adolescents with ADHD. So before we start talking about the specifics of ADHD, let's just go through the prevalence and the numbers. So as of 2016, 8.4% of U.S. children ages 2 to 17 were diagnosed with ADHD. Of those children diagnosed with ADHD, 62% were taking medications and 46.7% received behavioral treatment within the previous year. About a fourth of children diagnosed with ADHD did not receive any treatment in 2016. So let's go through the clinical presentation first of how to diagnose and what we're looking for when we are diagnosed with ADHD. So ADHD overall, according to the DSM-5, is a persistent pattern of inattention and/or hyperactivity impulsivity that interferes with functioning and/or development as evidenced by inattention and/or impulsivity. So in order to again, ADHD has the two parts, the inattention part and the hyperactivity impulsivity part. So in order to diagnose the inattention portion, according to the DSM-5, you need to have 6 or more of the following symptoms that are listed on the screen for at least 6 months. Now, if you're 17 and older, you only need 5 of the symptoms. These symptoms need to be inconsistent with the developmental level, and they need to negatively impact social and academic occupational activities. And so those symptoms include not giving close attention to detail and making careless mistakes, difficulty sustaining attention in task or play activities, does not seem to listen when spoken to directly, even in the absence of obvious distraction, does not follow through on instructions and fails to finish schoolwork, chores, or duties in the workplace, or starts tasks they'll start tasks but then easily lose focus, difficulty organizing tasks and activities, they avoid, dislike, or is reluctant to engage in tasks that require sustained mental effort, and they lose things necessarily for tasks and activities. They are easily distracted by extraneous stimuli, and this may include unrelated thoughts. So like if they're just daydreaming all the time, or they're forgetful in daily activities. So again, if you're under 17 years old, you need at least 6 or more of these symptoms to be consistent with a diagnosis of the inattention portion of ADHD for at least 6 months. Now, as the hyperactivity and impulsivity component of ADHD, again, you need 6 or more of the following symptoms. If you're under 17 and older, you only need 5 of the symptoms. And again, for at least 6 months, they are again inconsistent with the developmental level and again negatively impact social, academic, and occupational activities. So these symptoms of hyperactivity and impulsivity include often fidgeting or tapping hands and feet, or squirming in their seat, unable to remain seated still. Often leaves their seat in situations when remaining seated is expected. Running or climbing in situations where it's appropriate. In adolescents or adults, they may voice feeling just restless and unable to, get their energy out. But for younger kids, it's usually running and climbing on things that's not appropriate. Unable to play or engage in leisure activities quietly. These kids are often described as on the go or acting if they are driven by a motor. Excessive talking, blurting out answers before a question has been completed, in class, or even when just in conversation with someone. They will have difficulty waiting his or her turn, and then often interrupts or intrudes on others. Now, when we are thinking about ADHD, we have to have other consideration as well. So these symptoms are not solely the manifestation of oppositional behavior, defiance, hostility, or a failure to understand the task and instruction. So this is kind of, if you have these symptoms in those situations only, this may not be ADHD. So you need to make sure that these are not only symptoms that are in the times of severe oppositional behavior and defiance, or because the kid doesn't understand what's going on. These symptoms, the inattention, hyperactive, impulsive symptoms should be present several of them should be present prior to 12 years old. Now, it's not to say that they have to have a diagnosis prior to 12 years old, but when you are doing an evaluation, you should be able to ascertain that these symptoms were present in the patient prior to them being 12 years old, at least some of the symptoms. And then these symptoms need to occur in 2 or more settings. If sometimes people will come in and say, well, they're only like this at home, or they're only like this at school, and this needs to be, for ADHD to be properly diagnosed, it needs to happen in more than one setting. So it needs to be in 2 or more settings in order to properly diagnose. And there needs to be clear evidence that these symptoms interfere with their functioning on a social, academic, or occupational level, and they are not explained by any other mental health disorder. So my first set of clinical pearls is that back to the one setting thing. So if you have symptoms only in one setting, so only at home or only at school, one should consider other causes of the symptoms, which are usually psychosocial and or environmental in cause. So like if it's only at home, maybe it has to do with the parenting style of that parent in the home setting. Or if it's only at school, maybe that teacher struggles with appropriate classroom management skills. So you look into other things if you're only getting severe symptoms that are affecting functioning in one setting. Now, when you diagnose ADHD, you need to specify the presentation. So you can have the combined presentation where the patient meets criteria for both inattention and hyperactivity, impulsivity symptoms. You can have predominantly inattentive presentation, which meets criteria only for inattention, but not for hyperactivity and impulsivity. Or you can have predominantly hyperactive impulsive presentation where the patient only meets criteria for hyperactivity and impulsivity, but not for inattention. So to help with knowing if the symptoms are present in multiple settings, you need to consult with multiple informants who have seen the patient in other settings. So again, don't only get patient or family's report, but also get school reports. And if you're dealing with the adolescent, you maybe, see even if they would let you get some reports of how they're doing at work, if they have like a part-time job or something, to help you get that, to see how their level of function is in multiple settings. Now, this clinical pearl is really important because there are a lot of associated features with ADHD that a lot of providers forget about, and it's the low frustration tolerance that occurs with ADHD, irritability, and mood lability. So there's a lot of emotional component of ADHD that sometimes when people see those symptoms, they think, oh, this kid may have ADHD and something else, but that's not necessarily always the case. So in my experience, what I typically do is if ADHD is very, very clear and is very impairing that child or that patient in multiple settings, and they have symptoms of low frustration tolerance, irritability, or mood lability, I'm going to focus on maximizing the treatment for ADHD and try to get that under control first and see if those other symptoms of low frustration tolerance, irritability, and mood lability improve before I consider another diagnosis. So because it could be ADHD or it could be a co-occurring mental health condition such as depression, anxiety, or post-traumatic stress disorder, or other mental health conditions. So I want to make sure the one way to kind of help with that is, maybe focus on treating the one first and then kind of going from. So when we're thinking about along those lines, when we're thinking about the differential diagnosis, so when you have, this is another clinical pearl, when you have the chief complaint of poor attention and concentration or poor focus, please, please, please evaluate for other psychiatric conditions, because ADHD is not the only psychiatric condition which affects attention and concentration. You need to rule out major depressive disorder, because one of the symptoms of depression, one of the main symptoms of depression is poor attention and concentration. So it may be difficult to distinguish between ADHD versus major depressive disorder versus, both of them co-occurring because of the symptoms of irritability, which is very common in children and adolescents with both diagnoses. But you have to do the best that you can and ask questions to kind of tease the two out. Anxiety disorders are what also needs to be ruled out. Because anxiety disorders can present with symptoms of poor attention and concentration due to anxious thoughts. So if you have a kiddo that has generalized anxiety disorder, they may worry about so many different things, which is affecting their ability to concentrate on one task. And so, yes, they're not focused, but it's not that they're not focused because they have ADHD, but it's because their anxious thoughts are just running in their head constantly and they can't focus. Another anxiety type disorder is obsessive compulsive disorder, and the obsessions that patients have with obsessive compulsive disorder can interfere with their ability to concentrate, especially if they aren't able to do the compulsions to lessen the obsessions. So again, just because someone comes in with the inability to focus does not necessarily mean that it's ADHD through and through. We must do a full evaluation for that. Trauma and post-traumatic stress disorder can also affect attention and concentration. Intrusive thoughts and memories can impair the patient's ability to concentrate. And then also with PTSD, post-traumatic stress disorder, it can present with irritability and other mood symptoms too. So again, teasing out, is this ADHD alone? Is this post-traumatic stress disorder alone? Or is this a combination of the two? It's something that needs to be teased out. Psychotic disorders can also affect attention and concentration. Symptoms of poor focus and attention can be prominent in patients when they are experiencing hallucinations and or disorganized thinking associated with psychotic disorders. And then learning disorders. Children with undiagnosed learning disorders may have symptoms of poor attention and concentration due to not understanding the subject that they are being taught. And they may also have some oppositional and or disruptive behaviors in the classroom to try to hide that they're not comprehending. So there's a lot of things that we have to consider when we get the chief complaint of poor attention and concentration. Doesn't necessarily mean as soon as you see that chief complaint, that means ADHD. No, we need to definitely rule out other mental health conditions before we go to an ADHD diagnosis. And I bring this slide back up. If you all were present during my lecture series 2 weeks ago when I was talking about anxiety and depression in children and adolescents, this is one of my favorite pictures to utilize to show how anxiety can present itself in many ways. And in that green circle, I wanted to make sure I showed struggling to pay attention and to focus is a very common symptom and a way that anxiety can present itself. So now let's switch gears and talk about screening and assessment. So to screen for, when you're screening for ADHD, this should be done, the recommendation is to do this during the first mental health assessment visit. So if the kid, the family presents to you for some kind of mental health question, and this is the first visit that you are addressing this question, assess for ADHD. Ask questions regarding inattention, hyperactivity, and impulsivity, regardless of the chief complaint that is on, that you are given prior to seeing that patient. And ask if the symptoms cause impairment. You can give screening assessment tools to help determine if the symptoms are within the clinical range. And some of those tools you can utilize is the Conners rating scale, the Vanderbilt assessment scale, and then the ADHD rating scale 4. Now, these tools have both parent forms and teacher forms to help assess for the symptoms in multiple settings. Now, clinical pro at this is that the screening tools are just for screening and they are not diagnostic. So you will need to conduct a thorough evaluation to further assess the symptoms of ADHD after you received the responses on the screening tools. But the screening tools can at least guide you in how you want to assess for it, or if you even need to assess for it. Because if the screening tools don't, if they don't score high enough to a level to where it says this may be possible ADHD, then you may not even need to go into questions about ADHD symptoms any further or do any further evaluation for ADHD, because the screening tools did not flag to where you need to do further questions on that. Now, in your evaluation of ADHD, you need to perform a detailed interview with both the parent and the patient. And you need to ask the parent about each of the 18 symptoms that I went through, when we were talking about the presentation, and assess the age of onset of symptoms. Now, it's going to be kind of hard, for parents to remember all of those things, and they may have some selection bias with, remembering things, but, you do the best you can with the information that's provided to you. You ask about the patient's school day, like how they are functioning in the school or at daycare. If you are getting a lot of questions, or, the parent says, at school they get in trouble all the time, at daycare I've had to get them they've gotten put out of several different daycare settings because they weren't able to remain still, and they were, very rambunctious, and they couldn't focus and pay attention. And then at home, I have the same behaviors. They struggle with homework. We can't get anything done, constantly arguing. Those are things that the level of functioning. Also, when you're doing your evaluation, when I spoke about the differential diagnosis, evaluate for comorbid psychiatric conditions. Evaluate for comorbid psychiatric conditions and see if there's anything else present. So again, rule out for ADHD, anxiety, depression, post-traumatic stress disorder, learning disabilities, and then review the patient's medical, social, and family histories. ADHD is very, very, very heritable, so it's very likely that you're going to find ADHD symptoms and or ADHD diagnosis in parents and or siblings. And then also get a detailed developmental history, review the developmental history, because there are some developmental disorders that are associated with attention issues and hyperactivity. And so you want to make sure that you are not missing a developmental disorder that is not ADHD just because you are so focused on diagnosed ADHD. Now, as far as psychological or neuropsychological testing, it is not required for the diagnosis of ADHD, but it should be ordered if after you've done your thorough evaluation, you notice that there's a history of low cognitive ability, or you suspect an intellectual disability of some sort, or if there's low achievement in specific classes, math and reading, even though the child has a normal intellectual ability, because that could be a learning disability. And so sometimes it's kind of hard to tease out between an intellectual disability versus a learning disability without the neuropsychological testing or the psychological testing. And so sometimes that will be required. But overall, ADHD is a clinical diagnosis, and you do not need psychological testing to confirm that diagnosis. Now, sometimes parents may want that psychological testing because they don't agree that that's the diagnosis or whatever, and that's fine. You can get those results and share those results with the family, but overall you don't need psychological or neuropsychological testing to diagnose ADHD. Now let's go into treatment options. So with ADHD, you should have a comprehensive treatment plan developed for each of your patients. And it should include psychoeducation about ADHD and your different treatment options, medication and non-pharmacological treatment options. Research has shown that pharmacological intervention is more effective than behavioral treatment alone. However, behavioral treatment can be the initial treatment in the following circumstances. So if you have a kiddo that meets criteria for ADHD, but the symptoms are mild and have minimal impairment, you may want to refer them for behavioral treatment options to treat the ADHD symptoms, because they may be able to do some behavioral techniques and learn some behavioral techniques to where they can adjust to their symptoms without medication. If you are uncertain if ADHD is the diagnosis, then maybe you will refer for behavioral treatment first and see if symptoms improve after a few.
Dr. Johnson, I think we may have lost your audio.
What happened?
Okay, now we're back.
Okay, let me see if I can get it back up. I don't know what happened there. Okay, there we go. Is my screen still showing again?
It's good.
Okay, perfect. I'm sorry. So when parents reject medications, behavioral treatment is definitely appropriate initial treatment, because parents, a lot of parents have fears about ADHD medications. They make complaints about their kid being a quote unquote zombie on medicines and whatnot. And so if you want to help the parents feel better, I usually have no problem with giving behavioral treatment as the initial option for a few weeks, and then if things don't get better, we reevaluate and rediscuss medications. And usually by that time, parents are on board with trying medications. And then you can also do behavioral treatment as the initial treatment when there is a marked disagreement about the diagnosis between parents, so mom and dad don't agree, or between parents and teachers. So if again, that situation of their symptoms at home but not at school, or vice versa, their symptoms at school but not at home, and the parents and teachers are not on the same page as far as diagnosis, you may want to consider behavioral treatment as the initial treatment option. Now, there are also community supports that may be available, such as parent management training, and that's just to help the parents better manage the patient's symptoms. So teaching the parents how to deal with the kiddo's ADHD symptoms. And then additional school resources. So do they need an individual education plan? Do they need a 504 plan? Do they need additional time on tests and assignments, but maybe not have a formal IEP or 504 plan? Now, another clinical pearl is that neurofeedback has not been shown to be helpful for ADHD, and there is no food modality that has shown improvement in symptoms. I'm sure that if you all have seen a lot of ADHD kiddos, which I know you all do in primary care, there's a lot of questions about neurofeedback. There's a lot of questions about, well, if I give my child, omega-3, will that help? Or, less sugar in the diet, will that help with ADHD symptoms? And no research has shown that either of those things are going to improve the symptoms. So I tell parents that all the time. Now, let's go to the pharmacologic treatment of ADHD. So you're going to do pharmacological treatment of ADHD when symptoms are present in multiple settings, the impairment is moderate to severe, behavior interventions are inadequate, and or the risk of treatment outweighs the risk of non-treatment. So the first class of medications within for treating ADHD are the stimulant medications. And these are highly efficacious in treating ADHD, and they provide the most robust response in treating ADHD. So the stimulants are first line in ADHD treatment, hands down, especially if there is no comorbidity associated with that patient's case, which is not always the case. But in situations where it's just straight ADHD, first line is going to be trying the stimulants. Now, with the stimulants, you have two classes of stimulants. You have the methylphenidate class, which includes medications such as Ritalin, Concerta, and Focalin. And I'm using the trade names for the methylphenidate class just because, like, Ritalin is methylphenidate, and then Concerta is extended release methylphenidate. But to kind of help you all remember the difference of which trade drugs are in which class. And then we have the amphetamine class, which examples include Adderall and Vyvanse. Now, the stimulants have no matter which class you use, they have the same side effect profile. So the most common side effects are appetite loss, growth delay, which is a major side effect, but it's usually dose dependent. Headaches, stomach aches, and nausea, mood lability, and irritability. So remember that ADHD can be associated with mood lability and irritability, and then the stimulants can cause mood lability and irritability. So that's something that you have to watch out for when you're treating ADHD. There can be rebound hyperactivity. So basically the opposite effect, instead of them becoming less hyperactive, they become more hyperactive. And then sleep difficulties are very, very common as well. So the stimulant medication, there's a lot of clinical pearls on this slide with talking about the stimulant medications. So you can literally pick any of the two stimulant types. When you have a kid who is treatment naive, they've never been treated for ADHD, you can literally pick whichever class you would like, because they are equally efficacious. 70% of patients should respond to that first class attempted, and then 90% are going to respond to either class. Now, the odds of responding to the same class of medication, if there is no response, is very low. So you need to switch to the other class if you didn't get any response in the first class. So if I start with methylphenidate extended release Concerta, and I go all the way up to max dose 72 milligrams, and this kid doesn't have any side effects, doesn't have any improvement in symptoms, nothing looks different with the Concerta, I'm not going to switch to Ritalin and try Ritalin, or switch to Focalin and try Focalin. I'm just going to go ahead and switch to the amphetamine class, because this kid is not a responder, more than likely, to the methylphenidate class. So instead of switching within the same class, go ahead and switch to the other class if you get to max dose, or if you're not able to get to max dose because of side effects, but it's not improving the symptoms of ADHD, then go ahead and just switch to the other class. Now, at this time, there is no method to predict which stimulant will produce the best response in a given patient. Pharmacogenetic testing is not helpful for the stimulants, and from what I recall, most of those companies have removed the stimulant medications from their testing profiles when you do send off the pharmacogenetic testing, because they are not helpful for the stimulant medications. And the reason for that is because the stimulant medications have little to no metabolism in the liver, and the pharmacogenetic testing tests liver metabolism of medications. The amphetamine class has some liver metabolism, and then the methylphenidate class is not metabolized in the liver at all. So that is why the pharmacogenetic testing is not helpful for stimulant medications. So do not use that and think that's going to tell you how to prescribe, or which is going to which is going to be better for the patient, which is not what those tests determine anyway. Do not utilize them for that purpose for stimulants. Now, per milligram, the amphetamine stimulants are twice as powerful as the methylphenidate stimulants. So in general, when I have a kid that's less than 10 years old, I typically start with the methylphenidate class, because it will, to try to prevent that kiddo from experiencing severe appetite loss. Because again, the amphetamine stimulants are 2 times as powerful as the methylphenidate stimulants. So you can, if you start with an amphetamine, not saying that it's wrong, like if you start with an amphetamine and they're under 10 years old, that's completely fine. You can do that. I'm not saying you cannot, but I have seen a lot of kiddos under 10 struggle with severe side effects from the amphetamine stimulants when I start those first, or when someone else starts those first and then they come to see me. So I typically, if they're under 10, I typically pick the methylphenidate. But if you do the methylphenidate and there's no response to it, then you switch class and go to the amphetamine class, because it just may be that kid needs the amphetamine and not the methylphenidate. But in general, I try to start with the methylphenidate in kids under 10 years old. Also, in general, start with the extended release stimulants since it's an easier dosing schedule, once a day dosing. But just know that sometimes you may have to do an afternoon booster of the immediate release stimulant in that same class. You don't need to start with there's no need to start with the immediate release stimulant and figure out which dose works and then switch to the extended release. You don't have to do that. I know some people do that, and there are some cases where that's appropriate, and I'll talk about that in a little bit, in just a couple bullet points down. But overall, you can start with the extended release stimulant, get that once a day dosing, and then if you notice that there's some need for more treatment response in the afternoons, evenings, then you can give a booster dose in the afternoon to help get you through the rest of the day as needed, because sometimes that is required. Now, the immediate release stimulants usually require a twice a day or 3 times a day dosing to control ADHD symptoms. So it's not beneficial in a lot of situations, in a lot of cases. However, in those who may be sensitive to medicines, so this is a situation where I may start off immediate releases. If someone is very sensitive to medications, you might want to start with the immediate release to determine that the dose that works for them, and then change to extended release. Because the way I explain it to parents is, if I start with extended release and we know that this kid is very sensitive to medications, and they end up having a horrible side effect to the medication, it causes them to, let's say it causes rebound hyperactivity, and so they are just bouncing off the walls with the medicine, and we have to deal with that for, in theory 24 hours, but a long amount of time before that medicine is out of their system, versus if we start with the immediate release, if they do develop that side effect from the medicine, at least that side effect will be shorter lived than if we're dealing with the extended release medication. So in those that are very sensitive to medications and side effects to medications, I will stay away from starting off with the extended release. Now, I also will use the immediate release stimulants in small children. So if I've got a 3, 4, 5-year-old, and I need to start a stimulant in those ages, I will start with an immediate release stimulant in those cases, because there's usually no extended release formulation that I can dose as low as I need to dose for those kids, because I may need only 1 milligram of methylphenidate immediate release in a 3-year-old 3 times a day, versus needing 5 milligrams 3 times a day, which is the smallest pill dose in the smallest pill form. So you can for extended release, so you can, and then you can't, extended release pills you cannot crush or chew, which makes it hard for small children as well. So I typically will do an immediate release, because usually those you can at least crush or chew them if need be, or you can use the liquid version. And then another clinical pearl is that you can titrate your dose every 1 to 3 weeks until the maximum dose is reached, or until the symptoms of ADHD remit, or the side effects prevent further titration. So whichever one of them happens first, that's when you stop. So if the maximum dose is reached and you're not getting no benefit, that's when we're going to switch to the next class. If you get to a dosing level and the symptoms of ADHD are controlled and things are going well, then you stop at that dose. Or if you get to a point to where you're not maximum dosing, you're still having significant symptoms, but the kiddo has now developed side effects, then you stop and you don't titrate up anymore. So now we're going to talk about the non-stimulant class. So within the non-stimulant class, we have the alpha agonist, which include guanfacine, which comes in 2 versions: extended release, which is Intuitive, the trade name is Intuitive, or the immediate release, which is 10x. And I don't know that they call it 10x anymore, but it is still available as a immediate release guanfacine. That is still available. And then you have clonidine, which is extended release, trade name Capvay, and then immediate release clonidine. So the clinical pearls related to the non-stimulants. The alpha agonists are not as good for ADHD alone, but they work very well in combination with stimulants. I use the combination of a stimulant and an alpha agonist all the time, especially for sleep issues. That's what I'm getting ready to get to. The non-stimulant, the alpha agonists, are very effective for impulsivity and hyperactivity. They can help with sleep disturbances, so helping with insomnia. They can help with modulating moods, level, and aggression. And then they can also assist with if tics worsen with the stimulants use. So like if the kid develops a tic or they already have tics and the tics become worse with the stimulant, you can use the alpha agonist to help modulate the symptoms of the tics worsening. Now, the thing about the non-stimulants is, especially if you're using them alone, because I know sometimes in younger kiddos, we don't want them on a stimulant. We want to try, usually it's the parents too that wants that. And one thing about using the non-stimulants, alpha agonists specifically alone, is that you may not see an effect for 4 to 6 weeks of taking the non-stimulant. So when you use guanfacine and clonidine, you're not going to be able to see an effect for 4 to 6 weeks, which is different from the stimulants. With the stimulants, you should know within a few days to a week if it's helping or not, and if you need to go up on the dose. With guanfacine and clonidine, you're going to have to give 4 to 6 weeks, see if it's helpful, and then adjust the dose after that. And then the other clinical pearl for the alpha agonist is that you have to taper them off. Like say you get to a high dose and the kid needs to come off of it either because it's not effective or it's causing too much sedation or whatever. You need to taper off the dose slowly to avoid rebound hypertension with those medications, because low blood pressure is a side effect of those medications. Clonidine, that is what it is for. It is a blood pressure medicine, but it helps with the hyperactivity component of ADHD. So we use it in that setting. It's in that case. Now, common side effects with the alpha agonists include sedation, which is usually what we're using it to help us with. I use a lot of clonidine to help with sleep, insomnia in kids with ADHD a lot. Another side effect is headaches and then sleep disturbances. Sometimes I have gotten kids that, or parents that have complained that their kid is complaining of nightmares with the alpha agonist. So that is something that you have to watch out for. All right, so we're continuing with the non-stimulants to talk about atomoxetine or Strattera. Now, Strattera is a noradrenergic reuptake inhibitor. Clinical pearls for this, specifically for the use of ADHD. Clinical pearls for Strattera is that you should start 0.5 milligram per kilogram for the first week and then double the dose. After that, if you hit no effect on the full dose, so when you're starting it, it's just to prevent side effects. That's why you're doing that 0.5 milligram per kilogram for that first week, and then you'll double it for the next week, and then stay at that dose for about 3 weeks. And if you don't get any effect on that dose after about 3-4 weeks, go up on the dose until you get to the maximum dose of Strattera. If you're at max dose after 3 weeks and no effect, change to another medication. This one should be considered in those patients that have comorbid anxiety, substance use disorders, and or tics, especially if in the context of comorbid anxiety and tics, especially if the stimulants have worsened their anxiety or worsened their tics, then you want to consider Strattera for those cases. Another thing with Strattera is that I find that Strattera more so helps with more of the inattentive symptoms versus the hyperactivity impulsivity symptoms. So when I am using Strattera, I'm not really looking for it to help a whole lot with the hyperactivity and impulsivity symptoms. The common side effects with Strattera include headaches, stomach aches, and then very rarely suicidality, but that is a side effect. So we have to include that in our risk-benefit discussion. Now, bupropion or Wellbutrin is another non-stimulant that can be used for ADHD, and that is a norepinephrine dopamine reuptake inhibitor. Wellbutrin is third line. but it should be considered in children and adolescents with comorbid depression because, it's basically killing two birds with one stone. You're addressing the depression with the Wellbutrin, and you're also addressing the ADHD symptoms. Now, there is not a robust response to the ADHD symptoms with Wellbutrin, but the inattention focus does improve with Wellbutrin. You may not see much of a difference in the hyperactivity and impulsivity though with Wellbutrin. So clinical pearls. If the patient with ADHD has a robust response to the pharmacological treatment and is back to normal functioning, then medications alone is sufficient. You don't have to do anything else. If the patient has less than optimal response to medication, they have a comorbid disorder, or there are stressors in the family life which are usually present, consider psychosocial treatment, so behavioral treatment therapy with medication, because that is beneficial in those cases. You should continue to treat the ADHD symptoms as long as they are present and cause impairment, but just know that especially if the patient was started on the medication when they were very young and they get to be teenagers, most patients are going to stop their stimulants on their own at some point during the course of treatment. Whether it's, I want to see if I can do this without the medicine, or I'm tired of taking medicine, I don't want to take medicine anymore. Whatever the reason is, most patients are going to stop their stimulant treatment on their own, and then they're either going to see how things go without it and come back to you and say, "Oh, doctor, I made a mistake and I have to get back on my medicine," or they figured out how to make it work and they're doing fine without the medicine. It depends. I put this picture on the slide because this is from a website, www.adhdmedicationguide.com, and this was revised in November 2019. I love this. You can actually go on there and purchase this in a laminated form, and it has on one side, so this is one side of it. I use this in my fellowship program. We had them in our offices in my fellowship program. One side of it has the methylphenidate stimulants on it, and it's broken into long-acting versus immediate release or short-acting, and they update it every so often for any of the new ones that have come out, and it shows you the smallest pill form that they have, or in the of the patch, the smallest patch that they have, and go up to what the max dose is. And so this slide right here is showing the methylphenidate side, and then this slide is showing the amphetamine side of it, and then at the bottom shows the non-stimulants as well. So this is a really great guide. I absolutely love it. If I can't remember how small of a pill Vyvanse goes to, I can look on here and say, oh, okay, Vyvanse, the 10 milligram capsule, okay, perfect. Or the chewable, 10 milligram chewable, okay, perfect. So it's really, really, really helpful, especially so that you don't have to keep up with, because there's so many stimulants that are out there. You don't have to keep up with which is which, and it gives you, what the max dose is on here and the age range and all that good stuff. So I love this. And if you want to get this, like I said, you can go to www.adhdmedicationguide.com and purchase these in laminated form. And these are my resources. And now I will turn it over to you, Laura.
Great. Thanks a lot, Dr. Johnson. Just want to share just a little bit of information about CPAN. I'm just going to share one of our flyers with the group as opposed to going into our actual presentation. 1 second. Let me grab the right one here. So this is just some basic information about the CPAN program. This is if you're not familiar with CPAN, it is the Child Psychiatry Access Network. We are a network of 12 hubs located in health-related institutions across the state of Texas, serving all 254 counties. Texas CPAN is a service available for PCPs across the state to provide child psychiatry consultation, referral and resource assistance, and continuing education like you saw today. If you are a PCP and you're not yet enrolled in CPAN, this is available for you at no cost. It has nothing to do with insurance. This is just a support service for you. The state has funded these services and it's available for you. We just tell people, give us a call on the hotline, and that hotline number is right here, this 888 number. Based on the region that you're in, if you're in the Northeast region, you would then be contacted to one of our two therapists, either Elizabeth or Wiley, and they will answer your questions. If you need a consultation or would like a consultation with a psychiatrist, they will get that information from you that's for that consultation. That psychiatrist can either call you back right away, or we can go ahead and set up a time that's more convenient for you. Our average turnaround time on a call from a psychiatrist right now, as of last month, was 5.8 minutes. So you can have a quick call back. The turnaround time metric is 30, but we are doing a pretty good job at that right now. Or again, you can call and have us schedule a call back at a time that's convenient for you. Any questions, please either give us a call or you can email me in the chat. That's cpaninfo@uthct.edu, and I have that email address in there. And then I'm going to go ahead and ask a couple of questions for you, Dr. Johnson, and then I will show the QR code. So I have one question that is, what about parents who also have ADHD or have other psychiatric conditions and difficulty for them to tell you about the child's symptoms or diagnosis?
So that can definitely be a challenging situation, especially if the parents themselves have not been either formally diagnosed or they are in denial about their diagnosis. Usually, though, you can pick up whether they say yes or no to questions that you're asking. You can kind of pick up on subtle things that they might describe that you say, okay, this sounds along the lines of an ADHD symptom, so sometimes it may be a clear-cut thing of where you're saying, hey mom or dad, does your kid have struggles sitting still at home or at school? And then they may say no, but then you may continue to discuss with them how you continue talking, and they make comments like, every time we're at the dinner table, he just, he gets up and he just does not sit still while he's eating. Like, he gets up and goes and walks into the living room, and then he comes back to the table, and then he's on the floor, and then he, goes to the bathroom, and it just takes him all day to finish dinner. You got your answer to that question, even though they said no when you asked it in a direct way. That's what they said then, but you got an answer to, okay, no, they struggle with, sitting still in settings where they're expected to be sitting still, which is, eating dinner at the table. He's not, it takes all day to eat. It takes all night for dinner to get complete. It's like, oh, okay, so that's something that is happening. So it may not be in direct questions that you get your response. You might have to get creative and kind of have them discuss other situations that are going on with the kid in order to get those answers about ADHD symptoms in parents who themselves have ADHD, or, and usually it's the parents that are in denial. If the parents have ADHD and they know the symptoms and they benefited from treatment, they're usually the ones that are all on board with medications and getting the correct diagnosis and things of that nature. So it's usually the ones who are in denial about their own symptoms or their own presentation that you're going to get that conflicting information from.
Great. Thank you, Dr. Johnson. One more question here. And again, for the audience, if you'd like to ask a question for Dr. Johnson, please do add that to the chat. So the question comes from Dr. Neff. Is there a screening tool that you recommend for the young preschool age children, ages 3 to 5, that you suspect have ADHD?
You can utilize, like I said, the ones that I listed on mine. They both have parent and teacher forms, because the teacher is going to be the preschooler, the preschool teacher or whatever. So you can still use the Vanderbilt is still appropriate in those situations. The Connors is, and the ADHD rating scale 4 are appropriate in those situations. Do I I use a lot of the Vanderbilt just because I feel like that's the one that's the most known, and I guess that's the one that everybody learns about the most. So I use the Vanderbilt most of the time.
All right. And question is, at what age or how young do you start medications?
I have started medications as young as my age range for seeing patients when I was doing private practice outpatient. I did not see anyone younger than 3 years old, because even then, you're not going to expect developmentally, because again, this is going to be based on development. You're not going to expect a 1 or 2 year old to sit still, and even a 3-year-old, you're not going to expect to sit still in the majority of the situation. So, while I say that I started medications in someone as young as 3 years old, first I'm going to have mom or dad or both parents, if they're both in the home, or whoever the caregiver is, try to start off with parent management training and helping them deal with those symptoms. Now, when I will start medication in as young as 3 years old, and I've done this personally, is when those symptoms are so severe, the kid is at risk of hurting themselves because they're so hyperactive, they're not able to function. So I had one kiddo that came to me at 3 years old, and he was climbing. He would not sit still in the shopping cart while mom was at the grocery store, and he was climbing up and standing up in the shopping cart and was almost falling over and could have, hit his head on the floor at the grocery store and could have severely hurt himself. And he was running into traffic. So, he would just dart out of the car while mom was driving. I had to inform mom about child locks on the car because he was just running out of the car and running into the streets. And so when it was symptoms that were that severe and they could not be controlled, even with mom doing behavioral stuff, because we tried that first and it was just still too severe. Okay, we got to start something. And we were finally able to get him. He was constantly being put out of daycare. He had tried 4 different daycares by the time he had seen me because of his disruptive behaviors and not sitting still and running out of class and just causing all kind of problems. So we started him on low dose methylphenidate is what I used, and he was able to. We saw a complete 180 difference, and he was able to be much better with his behaviors. And again, mom was also doing behavioral therapy at the same time to help parent management stuff at the same time. And that combination together, he was able to do so much better. But it was at the point that the symptoms were so severe, I had to start him on medicine at 3 years old. I just had to.
Okay, great. Thank you, Dr. Johnson. I believe those are all the questions that we have today. I have posted the QR code on the screen for attendees to complete. Here's another question. How do you clinically address patients who are nonverbal, such as those with Down syndrome or autism, who may display symptoms of ADHD or where comorbid diagnoses impact assessments?
So those situations, especially those who are nonverbal, typically that's, majority of that information is going to come from other people. You're going to get the questions answered by caregivers and teachers is where that's going to come from. So typically I think of a kiddo that's nonverbal, as the same as if I'm dealing with a 3-year-old. A 3-year-old, I don't expect to give hardly any that I'm able to utilize, but I can get a lot of information from mom, dad, teacher, grandparents, whoever is involved with helping that child. It just may take you more time because you're going to have to ask more people to assess the symptoms of ADHD in those kiddos. But if you put in that effort, then that is going to be beneficial to you because you can better able diagnose the ADHD, because the more data you have, the more confident you can be in your diagnosis. So it's just going to require a lot more of data gathering and collateral information in those cases versus actually getting information from the kid themselves.
Great, Dr. Johnson. Thank you very much. It is the top of the hour. We appreciate you all joining us today. We have our next continuing ed will be on the 28th of April. Dr. Johnson will again be presenting, and she'll be presenting clinical pearls in the primary care setting. serving children with autism spectrum disorder, or it's something really close to that. But it is working with children who have autism spectrum disorder. Again, it'll be from noon to 1, April 28th. If you are interested in attending that presentation, please send me an email. My name is Laura Young. I am the program manager for CPAN here in UT Health Science Center. You can reach me at cpaninfo@uthct.edu. I've posted that in the chat a number of times. If you are interested in participating in the CPAN or the Child Psychiatry Access Network, we encourage you to contact the toll-free number, identify the region that you are in, and sign up. No cost, and it's like having a child psychiatrist in your pocket. Pretty excited about the services provided to you, and we are thankful for you today. Dr. Johnson, excellent job, as always.
Thank you.
Thanks all. Have yourself a great day, and I'll leave the QR code up for just a few more minutes.